Good morning, everyone, and welcome to our VCSQI SAN 2.0 call on alternative payment models. Welcome, everyone, and thanks for joining in this morning. Today we have Dr. Jeff Rich, who is our Chief Clinical Advisor, also former Director of Medicare, who will provide an overview of, brief overview of QPP and MIPS, and then we will launch into a more detailed discussion on alternative payment models. Dr.
Yeah,
Rich,
good morning, everyone. Yep. Go ahead. Thanks, Eddie. Good morning, everyone. Alternative payment models are very much in the forefront of payment reform for this year and for the years going forward. And so we wanted to discuss those. Next slide, under the context of understanding MACRA. So we have the Affordable Care Act, but an independent piece of legislation called MACRA, the Medicare Access and CHIP Reauthorization Act, which is the Children's Health Plan Reauthorization, was developed that repealed the SGR, which was a dysfunctional payment methodology for physicians, and developed a quality payment program, which you see on this slide, which has essentially two arms. One is the alternative payment arm, and one is MIPS. And MIPS is the Merit-Based Incentive Program, Physician Payment Program, and APMs are alternative payment models. So you have two pathways. One on the alternative payment side manages risk, and we'll discuss that because with advanced alternative payment models, you actually go at two-sided risks with a downside, a potential downside, as well as an upside. And MIPS is just managing penalties because MIPS, in essence, is rob Peter to pay Paul model, which is a budget neutral model for physicians. And so there will be winners and losers, much like there were under the SGR, except it's a little bit more forceful because it's actually legislatively mandated. And so it's going to be done, and there won't be band-aids put on it like there were for the SGR. Next slide, Eddie. You can see this slide that directionally where the payment system is going to go, so that by the end of this year, there will be 50% of payments based in alternative payment models, and the majority of them will be linked to quality, fee-for-service linked to quality, which we hadn't had before. So that's having a growing impact on the way we're going to be paid in the future. Next slide. So let's talk first about the Merit-Based Incentive Payment System, or MIPS. Next slide, Eddie. MIPS basically takes off the table the PQRS, meaningful use, the electronic medical records, and value modifier. So they're going to be, you'll be scored in 4 categories, which are listed here: quality improvement, accounting for 60%, advancing care and information is sort of, all right, participating in a database or working along those lines. Improvement activities, they're self-described, and then costs. So in 2017, costs were being tracked, but not part of the equation. The point here is that we're already under this plan, and we're already being tracked for quality. And this year, costs are going to be added to the equation. So 10% of payment will be linked to cost, and therefore they're beginning to develop increasingly a value proposition for healthcare. So next slide, the scoring. Each domain will be, a score for each domain will be established, and then the weighting of the domains will be applied. So they'll vary from year to year as things become more mature and as there's more strength in the financial accountability part of it. And then thresholds will be established by the secretary. So next slide, Eddie. As you can see here, this is pretty much the way the scoring system and the payment methodology is going to work. The top is MIPS, and in 2015 through 2018, we'll still be in PQRS and the value modifier and meaningful use, but by the end of this year, those will be completely withdrawn, and we're going to move into a pure MIPS versus an APM payment scenario. I think the thing that I want to point out most strikingly here is that from 2019 to 2022, the bonus, the upside, and the downside of MIPS increases to in 2022 there's an 18% swing between the winners and the losers. So it's a huge negative payment. CMS itself doesn't want physicians to stay in this model because it really pits physicians against each other, and it doesn't allow for great collaboration and things like that. Bottom line, you can see is that alternative payment models, particularly the ones that have two-sided risk, meaning that you can lose some money as well as gain money, but the swing is not as great. You get an automatic 5% bonus every year, plus you get an annual update that's 0.75% versus 0.25% in MIPS. So there are a variety of reasons to be part of an alternative payment model, particularly an advanced alternative payment model, and we'll talk about that. So let's talk about APMs. Next slide. So what is an APM? It's really a fusion of payment methodology that allows clinicians to be actively engaged in the payments that they receive. Some of these things are self-described and proscribed by CMS, but advanced alternative payment models can also be self-initiated by the providers. So you could write an alternative payment model that you'd like to be held accountable to, and get it approved by the Physician Technical Advisory Committee, and then it would subsequently go to CMMI, Center for Medicare and Medicaid Innovation, and the Secretary. Next slide. So you see alternative payment models is really developing a partnership with the clinician community. And it's not just physicians, it's all clinicians. Those extended clinicians, if you would, broadly placed physician's assistants, nurse practitioners, among others, and that list will grow. According to the Social Security Act, there's a list of about 30 clinicians that are actually in the Social Security Act. But what we're trying to achieve is high quality and cost-efficient care. And so you would design something or participate in something where quality as well as costs are measured, and then you would have the advantage to earn bonuses, and which are substantially better than MIPS, because the 5% bonus once you're in an advanced alternative payment model are not retractable. So you automatically get it just by participating. And as you can see in the bubble diagram here, advanced alternative payment models are going to be a reasonably large part of the payment systems, and will continue to grow over time. Let's go on to our next slide. So an advanced alternative payment model are, as listed here, you get the 5% lump sum incentive, and then you get APM specific rewards. So if you design your own, for instance, you could figure out what you want to deliver to your patients. So if you're in cardiac surgery or in dermatology or some other area, then you could decide what's important to your patients, and you could set those goals for yourself and achieve those goals and be a part of a bonusing system. The next slide really gives you an idea of the APM framework. So most of fee-for-service is the very first box, category 1. And then as you move across the spectrum there, where you're going to end up is category 3. So for instance, Medicare Shared Savings Programs Track 1 are category 3A because there's only gain sharing, there's only upside incentives and no downside risk. So when you get to 3B, that's where you have a downside risk. So a lot of these, the upside risk may be 5%, or upside gain sharing 5%, and the downside risk may be 2%. But as you develop your own model, you can obviously develop it so that you could perform well and gain that bonus. So category 3B is kind of where this healthcare system wants to go. CMS wants to go with all of this. Category 4 are population health, which are on the radar screen but not ready for prime time yet. And if you go down to the next slide, Eddie, as you can see, again, I'm going to just keep reiterating that the 5% lump sum bonus is available in an advanced alternative payment model, which advanced meaning that there is some downside risk that you're willing to take, but most careful providers will be able to succeed. This is not a budget neutral situation, so there's monies already allocated for through 2024 for the bonusing system. So it's not something that has to be worried about. It's going to be there, and it's already established in the budget. Next slide. If you're a qualified participant, you are automatically excluded from MIPS, and you receive the 5% lump sum bonus, and again, the higher physician fee schedule update. Next slide. The yellow box is highlighted. Some of you may remember that CMS came out with a mandatory cabbage bundle, which was retracted because the provider community did not feel like they had enough input into it, so it was pulled. But what is on the radar screen right now are voluntary bundles, which allows you to participate in an advanced alternative payment model without having to design your own, and you just have to figure out if that's where your comfort zone is for that. And we're going to talk a little bit more about that. Next slide. So where are we going? 30% of Medicare payments in alternative payment models in categories 3 and 4 already here. End of 2016. In fact, we were beyond that. In 2016, we're something like 33%, and it escalates till 2019 when 85% are going to be in category 3 and 4, hopefully. And some alternative payment models that are out there. I mean, some of you may already be participating in an accountable care organization. A lot of these are primary care, so the advanced primary care model, and then bundling is the hottest thing that's being worked on now at CMS and CMMI. When there was a pause that was taken, but now it's moving ahead. So next slide. Getting ready for MACRA. So the next slide here is our bundle payments generally. I just wanted to say that Part A and B are paid separately right now. Part A being the hospital payments, Part B the clinician payments. And it's all fee for service, so it's compartmentalized, so there are components that are paid independently. On the bundle payment side, you pool both of those together, and you give one single payment for an episode of care, and depending on the windows that you wrap around it, it could have 3 days of a pre-episode window where all the testing that is done is paid for under the bundle, and then anywhere from 0 to what's typical, not typical, but often talked about as 90 days of post-operative care involved in your bundle. So what CMS and CMMI want us to go at risk for is just care delivery beyond just the episode of care, so that we stay coordinating care with our patients and making sure that they're receiving well-coordinated care and et cetera, et cetera. Next slide. So the new bundle payments, they've now come out with voluntary bundles, 32 different episodes of care, and they are 90 days post-operative or post-episode window. We have 29 inpatient episodes, 3 outpatient episodes. These do qualify as an advanced alternative payment model, so it means if you volunteer for them, then you'll automatically get that 5% bonus. And so, as it states here, payments tied to performance and target prices. This is all something that's being developed. So the message, I think, to all of you will be that you have to sign up for these by March 12th, which is not too far away, but let's get to that first. But the key stakeholders on the next slide, the acute care hospitals and physician group practices, and all of the other participants can go in as a convener participant, which means you're starting the bundle, you've taken on the risk, and so you're considered a convener. The next slide shows the 29 inpatient bundles. I'll focus, there are a number of them that are cardiac specific, like arrhythmias, defibrillators, valves, and coronary artery bypass grafting. And you can see the list here, pacemakers, et cetera, PCI. These bundles are being developed as we speak, and they still need clearer definition. These are inclusion bundles versus exclusion bundles. So, I'm sorry, they're exclusion bundles rather than inclusion bundles. What does that mean? So on a design principle, what you do is you include everything and you only exclude certain things. So like a snake venom bite or something might get excluded in the bundle, whereas on an inclusion design bundle, you figure out what you want to put into it rather than just taking the entire universe of codes and starting to exclude things and erase things along the way. They're a little bit more fair if you do inclusion, but they're much more difficult to do. And I've been working with inclusion and exclusion bundles with MACRA. I was the co-chair of the MACRA Clinical Cardiovascular Committee. So next slide, we have 3 outpatient episodes that you can see here: PCI, defibrillators, and spinal fusions. All make sense. So your next slide, your other options are to either participate in one of those or create your own. As I said, you could come up with something you'd want to be. It doesn't have to be bundle payment model. It could be a model where your performance is linked to payment, and that you will take some risk if you don't perform well. You set your own thresholds, and if the metrics are reasonable and the thresholds are reasonable, then it could potentially get approved by CMMI. Back to my comment about the voluntary bundles, you have to sign up by March 12th. It's an opt-in situation. If you don't do it by March 12th, there's going to be a 2-year pause where you can't get into it. So then you'll be stuck either designing your own or looking for something else that has already been listed, or staying within MIPS and working within MIPS for the next couple of years. The thing is, because there's a lot of ill-defined things around it, that there's a grace period where you sign up by March 12th, fill out the application and do it, and then by August 1st you can opt out of it once you get clearer definition for what's clearer. Well, what's not clear right now is the pricing methodology for a lot of these bundles, and so that's being worked on now by CMMI and CMS, and they have to come out with that and share it with providers before you have a final bailout point of August 1st this year. You can always bail out with no consequence. So I'm going to stop there and see if there are any questions, and just open it up for questions. Thanks.
Hey, he's not coming. No, and Rachel
Hello?
and are coming to do some to filter out some of Natalie's stuff. So he's not coming because he responded back to me saying he.
I think there's a little background.
Yeah, there's
any other questions or comments? There was one question yesterday, Dr. Rich, during the evening session from Steve in Orlando, and I think Steve's on right now. Steve, do you want to address your question?
Yeah, Eddie, that's fine. Go ahead and ask if you like, and I can add in if I need to.
So I don't think I'd be able to provide too much detail, but I know there were some questions, Dr. Rich, with regards to attribution models on the bundle payments and how those would get divided. And Steve, do you want to go ahead with the rest of the details?
Yeah, if I was looking at the BPCI Advanced, the fact sheet that was sent out, there is on page 4, it talks about the clinical episode attribution. And it specifically, it goes into how the attribution applies. And if the physician group practice that submits a claim that includes the NPI for the attending physician, it looks like that's the first attribution test that they make. And then number 2, it says the PPG that submits a claim that includes the NPI of the operating physician. And finally, the ACH that submits the hospital claim, I guess. My question on the attribution is how is that attribution made? Is it based on the first physician group that submits the claim, or is it based on the hospital's claim that goes in, or is it based on the surgeon's claim that goes in? A specific example of that, Dr. Rich, would be if if we pick up a patient, let's say, for example, on an inpatient basis, as soon as the patient is admitted, we're consulted by the cardiologist on this patient, and we submit the claim for inpatient consult. Is that a triggering event for that clinical episode attribution to our practice? And then how does that all work? Or I'm just not sure how Medicare makes the attribution decision.
Right. So there are a couple questions embedded in your single question. One, are the windows wrapped around the episode? What are they? How do you define them? So in the particular case you're talking about, if somebody comes in with unstable angina, gets catheterization, and then goes to have coronary bypass grafting, one model would say that everything that's done regarding the bypass operation, including the catheterization, is included in the total cost of that episode, and then all of the care following it. So with respect to attribute, and that's a little bit tricky because having been on the clinical cardiovascular committee for MACRA, we debated this for over a year and a half. So believe me, it's not a simple answer when you get to it. And what we have right now, like for instance, percutaneous intervention, PCI, and STEMI with the PCI have 0 windows beforehand. So nothing that happened to the patient before they went for their episode of care, their procedure is counted in the attribution model. And we have a 30-day follow-up window. So it could go, it varies quite a bit, and it's all about bundle design. Some of those windows go out 90 days. Some of the proposals were up to 90 days beforehand and 180 days after, which is basically population disease management. So it's all tricky. But attribution, so what happens for the attribution itself is all the revenue codes and CPT codes and things that are given or done to the patient during the episode are put into a grouper, and the grouper has system logic built into it that goes through those and filters out those codes and attributes them to the episode. So for instance, if you're having a coronary bypass operation, but you're also getting chemotherapy for ongoing treatment for colon cancer, those aren't attributed. So there's a logic to it. So there's definite exclusions, but it takes a long time, and we've been working with Acumen, and I've been working with with Brandeis University to try and figure out how you attribute those. So then you go to the final step. There's like, all right, so now that you have all the appropriate codes in the grouper's system logic has sorted them out. So there are buckets. So this episode of care has all of these revenue codes, CPT codes, ICD-10 codes in there. How do we attribute it? So on the physician side, these are physician models now we're talking about. On the physician side, you are attributed it based on 2 models. One is a proportionality model, or one is an all or nothing model. So the all or nothing model is the one that the PCI and STEMI with PCI is doing. So the person who has contributed more than 30% of E&M codes during that episode gets attributed all of the costs of the entire episode, which is very debatable. And, we've had many, many conversations about what the right thing to do. I was always in favor of a proportionality model, so that everybody, if all the codes, if you could sort them out. The problem is it's hard to sort them out. Like who ordered the CBC? Who ordered the chest x-ray? So if you could potentially do that in theory, then you could proportion it out among the 6 care providers who touched that patient during that episode. But again, it's pretty tricky to figure out who the ordering clinician is on a lot of those tests. So that's why we ended up agreeing on the 30% model, but that is controversial, I'm telling you. And we finally decided after a year that we were just going to roll out this model and see how it worked and get feedback from the involved clinicians. And I don't know if that answers your question, Steve, because it's pretty complicated when you start talking about attribution and how you proportion it out and who's responsible for what during an episode of care and who touched the patient when and who ordered it. So it's not really clearly defined as well as we like it, but it's legislatively mandated, so something has to roll out. And so that something is kind of what I just described. The next phase 2 of the macro clinical committee, is going to touch on an expansion of the interventional cardiology, as well as probably cabbage and bells, among other things going forward. So, Steve, did that help confuse you, or did it help you understand a little better?
It was very good. The reason I asked the question is that I was just reviewing our 2017 QRUR reports. And as I was looking at the attribution of some of the cases on the QRUR report, and in one or two of the instances, some of the costs were associated with our practice because we had submitted the initial consult for the patient, and the total cost was attributed to us, and that was just always been a question that I had, and especially again this year when I saw the same thing. And as we start moving into these more detailed models, and then when under the MIPS next year, when they add the cost section in there, then basically that's an attribution that we really won't have much control over until they do the reports. If that makes sense, what I'm saying.
Yeah, no, it does make sense. That's why it took us a year and a half to even get to the point where we simplified it as much as we could. But even you have even with like Brandeis University, who's doing some work with CMS on this, with the American College of Surgeons, and Acumen, which is doing the work that I was working with them with CMS on the macro committees. They have different system logics, and it's really, I mean, I spent months and months going through 9,000 codes trying to figure out which ones fit into certain categories for different episodes of care. So like you said, it's going to get even more complicated. So in one sense, I think it's a little frightening, if you would, going forward, that, we don't have it well defined, but unfortunately, unless Congress acts to withdraw the law, which it has to be an act of Congress, we're going to have to move forward with something. But my sense is that this is really an era of opportunity for us, because we can help design and redesign and refine all of these models to make so that they make perfect sense for us as providers going forward.
Correct. And I agree. I appreciate that.
Any other questions or thoughts? Those are good questions, Steve. Thank you for bringing that forward.
I do have another question, and I hope it's not too detailed, but in looking at whether to apply for the BPCI Advanced as a convener or a non-convener participant, here with our practice, Dr. Rich, we do work closely with the hospital, but I'm not sure that the hospital is going to be able to complete an application by March the 12th. I'm not sure that we would either. So as I'm looking at the instructions, I'm thinking it would be better for our group to participate as a non-convener participant, because we would be the only EI. I think that would be, we wouldn't be controlling any other EIs, and in a model where we would be a non-convener and where the ACH would not be participating. Do you see a lot of practices where they elect to participate as a standalone practice, like a PGP, without the ACH participating?
Yeah, I don't know, because this is all new and coming forward, so I haven't really seen or talked to a lot of people as to how they're filling out the application, either as a convener or a non-convener. But I think your approach is one that's reasonably safe and probably makes the most sense, because if you want to, take on the responsibility of others' actions, that's up to you. But it's clearly going to be a lot harder, a hill to climb, than if you're just responsible for your own actions.
Correct. Okay. Excellent.
Very good. Well, we're just about at the bottom of the hour here. Dr. Rich, I don't know if you had any closing comments or any other things you wanted to leave the group with.
No, I could just say that, consider going and filling it out for the voluntary bundles. The applications aren't short. I think they're like 28 pages or something long, but I haven't actually gone through it. A lot of it are instructions rather than blanks that you have to fill in. But you know, if you want to not do that, that's fine. But just be remembering that you'll have to be part of MIPS for the next 2 years, because there won't be an open enrollment period again for 2 years. So that's my only thought. I think, as I said, I think, you know, I would certainly be thinking very strongly about moving towards an advanced alternative payment model. And you never know that this opportunity may pass you by, but there may be another bundle payment model that comes out from CMS, you know, in a year, so that you can participate. So all will not be lost if you don't jump in and fill out that application. But on the other hand, if you can do it, if you have the time to do it, like you said, Steve, and you can get it done, at least you have the opportunity to opt out by August 1st once you get better definition about what these things actually look like from the pricing methodology. Because I think that's where the majority of worry should be, you know, because I'm not sure that CMS is going to quite have it pulled together well enough, because on the pricing methodology for the mandatory cabbage bundle, it was regional pricing, which I thought was quite dangerous, and I was pretty vocal with them about not moving forward with that, because it was going to be very dangerous for, you know, if you were comparing the region and it's Northern Virginia and Washington, D.C. compared to Roanoke, and you're going to get somewhere in the middle, that's going to change a lot of the way access is performed throughout the state. So I hope it's not going to go to regional pricing, but we'll see.
Very good. Well, we appreciate you all joining us here this morning. And of course, we're happy to help out with any additional questions you may have on APMs or anything MIPS and QPP related, as VCSQI strives to help you all succeed in value-based payments.
Yes,
so
thanks
everyone.
Yeah, thanks.